it on. Now I'd like to welcome Michelle Solon from George Washington University Hospital to present on empowering rehabilitation therapists to prevent hospital readmission for the uninsured populations. Michelle, take it away.
Hey, good morning. So we'll jump right in on the next slide. When thinking about the scope of the problem of people without insurance in the United States, we know that this is a large problem, right? So there's 27.5 million people in the US and 22,000 here in DC without insurance. We also know from the literature that people without insurance receive different care, unfortunately, than those with insurance. And from firsthand experience here in the hospital, as part of the interdisciplinary team and also for patients, we understand that lack of insurance can contribute to challenges creating a safe discharge plan, especially for those folks with functional impairments. Next slide. As PTs, as OTs, and speech therapists, we are uniquely positioned to intervene on a patient's functional impairments. And specifically at GW in 2018 and 2019, we made a couple of changes that we think have positively impacted our care for uninsured patients here. So we'll discuss further later on, but we implemented the rehab clinical specialist and made some changes to our communication strategies. Next slide. So our objectives here are to determine the impact of increasing access to hospital-based rehab services for people who are uninsured, to describe the role of therapy services for those who are uninsured, to determine if increasing rates of therapy for those who are uninsured can improve rates of readmission, and to identify some reproducible strategies to facilitate safe discharge for those patients. Next slide. So here our methods are really just honing in on our population of interest and looking at the numbers. So broadly, we're looking at number of admissions for 2018 and 2019, then the number of uninsured admissions, then the number of uninsured admissions with at least one billable therapy service. Next slide. We wanted to look at those with greater than average length of stay as a very broad indicator of increased medical complexity. So here, average length of stay is 5. So we're looking at those folks without insurance with length of stay greater than 5 who received therapy compared to those who did not receive therapy. Next slide. We defined readmission as any return to the hospital within 90 days, and then use that as another criterion when looking at our uninsured patients with length of stay greater than 5. Next slide. We also did a case study that we'll get into a little bit later, just looking at 2 patients who fall into that category of those without insurance with length of stay greater than 5. Next slide. So this is what our numbers looked like, and broadly from 2018 to 2019, we can see that across the board, everything is increasing, more hospital admissions, more admissions for those without insurance. In the following slide, we're going to look at kind of the rightmost column for 2019, the uninsured admissions kind of going down from there. Next slide. So here's a graphical representation, and the green and yellow categories here represent those patients who have had at least one billed therapy service. So we in total have seen about a quarter of those patients. But if we wanted to look at just those patients without insurance who had length of stay greater than 5, that would be the yellow and blue categories. So yellow would be those patients who received at least one therapy, and blue, those who did not receive therapy. We'll explore those 2 categories further in the next slide, which we can look at now. So here we're looking at percentage of readmission among those 2 groups. So we can see on the left side, those who received therapy were readmitted 16% of the time compared to those who did not receive therapy and were readmitted 21% of the time. So that did end up being a statistically significant difference. We can look at the next slide as well, where we see our numbers of therapy visits increasing from 2018 to 2019 across all services. Next slide. If we wanted to look at 2 specific studies here, these are both gentlemen who had acute hemorrhagic strokes. Our rehab clinical specialists worked very closely with both patients, and we can see, so we're using the FIM here, it's the functional independence measure. Lower scores indicate need for greater assistance, so the blue bars on both graphs indicate that at admission, both of these patients needed a significant amount of assistance, a lot of help. The orange graph and the orange bar and the gray bar indicate later dates, so either when they were discharged to the community, when they were discharged to rehab. And we can see by the time they went back to the community that these are both gentlemen who were largely independent or modified independent with those numbers 6 and 7. That's what's indicated there. Next slide. So in conclusion, we can see that rehab therapists do use a distinctive approach to address the many barriers that patients without insurance face. Retrospective study seems to give initial indication that increasing frequency of therapy may help reduce hospital readmission. And our case study allows us to look at aspects of a plan that will hopefully expedite interdisciplinary planning for safe discharge. Next slide. To that end, the rehab clinical specialist here has really taken on a lot of the work of so-called like rehab in place. So that would involve seeing patients for increased frequency, longer sessions, using clinically advanced techniques, advocating for charity services when appropriate for each patient, as well as mentoring other therapists who may feel challenged kind of when looking at what is the kind of best practice for patients with limited number of resources due to lack of insurance. Next slide. In terms of the communication routines that were augmented and improved in 2018 and 2019, there were hospital-wide interdisciplinary rounds that were implemented. We had a practice of quickly identifying uninsured or even underinsured patients on our scheduling system so that only those therapists that we're treating were aware just in terms of HIPAA compliance. We're using HIPAA compliant messaging apps for very immediate, communication as we are learning information perhaps in the moment during a therapy session, and the use of work phones across several departments. So all of that, there's some redundancy there, but it allows us to make sure that our messages are being communicated immediately and very clearly to all relevant parties. Next slide. So there were some limitations here. Of course, this is a retrospective study and a case study. There's no control group. It's a limited scope. We're just looking at the past couple of years. We used length of stay greater than 5 as a marker of a more complex patient, which may not always be the case. There was no further refinement of population by diagnosis or comorbidities. So a little bit of room for growth and further studies. I think the last slide here is my references. So I'll be happy to take any questions that have come up.
Thanks, Michelle. Like I said with the last one, these are also different and yet to me just fascinating given the field that I happen to be in. You know what, I'm going to start with the same question I asked the last one in terms of sort of buy-in. Was this something that the team brought forward or was this something that came up as looking at some data? How did the idea come to fruition?
Yeah, so we kind of came up with this idea among ourselves. I'm here with some of my group members, so I can introduce here as well. We're having a socially distanced summit of our own over here. But this is something we came up with ourselves, just kind of knowing the work that we've been putting in and also recognizing that it is unique compared to other places that we've worked. And also, seeing kind of increased frequency that this is happening, we wanted to have an approach and kind of evaluate the approach that we've been using thus far.
Makes sense. I noticed you mentioned that you were looking at readmissions in 90 days, and a lot of these things that are publicly reported are 30. Did you do some breakouts for smaller time periods, or were you thinking about doing that, or was that 90-day period one that made sense for you based on what you were looking at from the data?
It made sense based on what we were looking at the data, but there's definitely room for further study there. And we understand too that sometimes we are looking at someone's initial history of present illness and it mentions that they came from another hospital where they were not so long ago. So there's a lot that's not reflected there, but kind of just an initial look there.
You mentioned your socially distanced virtual summit. We love that. And that actually, I think, leads into the next question that we had come through. With COVID, it exacerbated some of the social determinants of health, particularly for the uninsured and underinsured. Did you have to do anything different to support patients during the pandemic, or was the fact that you had this structure in place more helpful? What do you guys have to share about that? You're looking at your colleague, put her on the spot.
Hi. So I think one new factor during the pandemic is with discharge planning, often the possibility of someone going home now has a new factor of, is the home being quarantined? Is that going to impact length of stay? And I think that's been a definite change in this season. The factor of not just a location, but is that location safe now for another reason? But ultimately, I don't feel like our process has changed. It's more of the environment and the world is changing and we're adapting with it.
Right. That makes sense. Thanks so much.